So here's our poster presentation about the somatosensory system. My name's Emily, and I'll be doing the introduction and gross anatomy sections. So the somatosensory system is important because it's responsible for the perception of pain, temperature, fine and more broad touch, vibration, and joint position, also known as proprioception. It's basically how we experience things through our skin. The somatosenses are separated between inputs from the body or the head, and they can also be separated by the modalities such as pain and temperature or vibration and proprioception. Basic understanding of the gross anatomy of the human is important in order to make comparisons to other creatures and their anatomical structures, and then to apply insights to clinical cases involving the types of dysfunction that can occur from this system. And so for the gross anatomy, looking at figure 1, there's the pathways, the two main pathways, which are pain and temperature, and the other is vibration and proprioception. The pain one is the yellow part of the diagram, and the vibration and proprioception one is the pinkish orange one. And so following the vibration and proprioception pathway first, both of them come in through the dorsal root ganglion from the body, and they enter the spinal cord. And the vibration and proprioception reaches the posterior column of the spinal cord and starts to ascend until it gets to the brainstem, at which time it makes some connections in the nucleus gracilis and then crosses over through the secondary decussation. And then it continues to ascend, as it's now called the medial lemniscal pathway, up until it reaches the thalamus and the VPL, specifically the thalamus, where it then will be projected out to the primary somatosensory cortex. So then going back down to the yellow pathway, which is pain and temperature, also enters the dorsal root ganglion. It crosses over in the spinal cord instead of higher up. And so it crosses over, and then it ascends through the anterolateral pathway on the opposite side of where the receptor is. And it just ascends all the way because it's already crossed over. Once it reaches the brainstem, it becomes called the spinothalamic tract instead. And it also goes to the VPL of the thalamus and then projects out to the cortex. And so then in figure 2, the figure 1 was just talking about body inputs, and then figure 2 is about the inputs from the face, because the thalamus separates it combines all the modalities into one and then separates it then instead based on where it originates from the face or the body. And so the facial stuff is almost entirely controlled by transmitted by cranial nerve 5, the trigeminal. And so the second pathway on the right is the vibration and proprioception part. And so some of it stays on the same side and ascends through the dorsal trigeminal tract, and other parts of it crosses over and ascends to the medial lemniscus. And then the pain and temperature information instead, which is number 4, goes down from where it started and then makes connections in the spinal nucleus and crosses over there, and then ascends to the spinal thalamic tract. And then all of this somatosensory information from the face now goes to the thalamus, and it connects called the VPM instead of the VPL, which then both of them will project to their proper places in the somatosensory cortex. And now Robert will move on to the comparative anatomy section.
Hello, my name is Robert, and we're going to be talking about 5 or so different comparative anatomy examples that we found dealing with the somatosensory system. So first, I had found that fish and amphibians typically only have 10, not 12 cranial nerves, because they're going to lack accessory and hypoglossal nerves. They typically don't really need them as much as we do. The motor control and the trapezoid turning of the neck and things like that, they don't really do as much. They just kind of glide in the water. Another thing that we had found was the whisker system in things like rats and foxes was actually really interesting. It's a sensory motor system used by animals like rodents and foxes. And the nerve endings in the whisker follicles, they end up being able to transmit information to the somatosensory cortex. And so, for example, rat whiskers are highly sensitive to touch, being able to just walking, brush over ground. If they get bent when they touch food or obstacles, some other animal or something like that, as soon as it bends, it's going to be able to send a message to the rat's brain all the way into the deep brain stem nuclei, and the rat's going to be able to tell the direction, left, right side, how far up the whisker, etc., if it's close, if it's in danger, things like that. And the whisker barrels, basically, it's mapped out topologically, and there's three main sections to it. Also, what I also found interesting was there was a study with tree shrews, and their goal was to kind of compare the dorsal column nuclei and the spinal pathways to the brainstem and thalamus within them compared to us. And what they were able to find is that they have efferent fibers. Their dorsal column nuclei, basically, they terminate. Yeah, they go to the thalamus like ours do, but they also terminate deeper into the inferior olive, like external nucleus of the inferior colliculus area. And sometimes, not sometimes, but like some of them even go all the way deep into the pontine nuclei, which basically the whole case study kind of indicated that their dorsal column, it's generally deeper, and it's more of a complex pathway to the thalamus and other components of the brain compared to ours. And finally, an interesting one that we had found and discovered was the star-nosed mole, which is in figure 9 on the top right. And basically, these are little mole rats who have 22 appendages kind of on their face and more or less the shape of a star, which is why they're called the star-nosed mole rat. They are called Eimer's organs, and they're highly sensitive. They have roughly 25,000 kind of like projections on these on these appendages, and they're used to detect touch, sense vibration. They're extremely sensitive. They're known to be some of the most like a sensitive animals, is what some of the scientists have termed them as. And their size definitely doesn't dictate their ability, because they're able to, although they're small, they're made to find even smaller things, which is why they're so good at like touching even the smallest vibrations from, say, an insect or something like that. But basically, there was a study that showed that their somatosensory cortex is unusually lateral in their orientation with in their brain. And it's more kind of caudal as well. Interesting enough, they found that the auditory cortex, in comparison to this, is more caudal as well, because it's not necessarily as used as much, as well as the visual area is pretty small in them because of the specialization to the star nose. They think that more effort and energy and time and evolution, stuff like that, has been put into the nose and their touch sense over the other senses. And so Corina and Taylor are going to take the rest of the clinical case studies.
Okay, so my name is Taylor, and like Robert said, I'll be looking at some of the case studies. So for case study 1, with any of these, we want to ask ourselves a set of questions so that we can try to determine what's going on with the individual. So in case study 1, we have a 24-year-old man who was rushed in the emergency room with a seizure, and he had a 7-year history of partial seizures, about 5 to 10 a day. And he was also experiencing increasing dysesthesia and pain on the right side of his body. And so these symptoms are obviously associated with the somatosensory system, because he's having that dysesthesia, which is, kind of like a burning sensation, an abnormal burning sensation. And if we look at the scan, we can see a horizontal flare scan of the brain, and you can see that there is a parietal lobe lesion. And this is important because the parietal lobe contains the sensory cortex, which would explain some of the dysesthesia he's experiencing. And this tumor itself actually also extends down to the posterior insular point. And while it's uncommon for seizures to occur because of this, it actually did result in the patient being diagnosed with S2 epilepsy. And so why was this a progressive thing since it was increasing dysphagia? It's because it is a type of tumor that is growing. And so as tumors increase in size, they can result in increased symptoms. For case study number 2, we have a 6-year-old boy presenting mouth drooping and a mild hemiparetic gait. He also has left facial nerve palsy and weakness and loss of feeling in his left limbs. And so immediately the left facial nerve palsy points to cranial nerve 7. So we could ask ourselves, like what usually causes that type of symptom, and that would indicate that. And where is a lesion? We can see in the sagittal T2 weighted scan that it is near the pons. And why is this important? The pons has many nerve connections that run through there, kind of right in that area, including facial nerve 7 and including the corticospinal tract. And so if there is pressure being put on this pathway from a growth, it would explain why he's having some nerve palsy and he's having weakness and loss of feeling in the left limbs. And even though this case is more of a motor loss type case, especially since it is near the pons, we can describe it as having some somatosensory like symptoms as far as the loss of feeling and weakness.
For case study number 3, we had a patient who was a 52-year-old female. She suffered head trauma resulting from an in-car traffic crash. So a vehicle hit the side where she was sitting and her head hit the door. She did suffer a flexion hyperextension rotation injury, and she began to feel headaches in both the frontoparietal occipital areas approximately 2 weeks after the crash. She also did lose consciousness for 30 minutes during the crash, and she again experienced that headache, that constant headache after 2 weeks. So we can kind of think about if there was a headache after 2 weeks, maybe there was some type of tumor and it was going ahead, and maybe there's something like with hydrocephalus. However, when we're presented with our T2, with our diffusion tensor tractography, we can see the spinal thalamic tract is narrowing in both hemispheres. And we can attribute this to be something going on with the somatosensory system because she has pain characteristics such of neuropathic pain, such as the tingling or stabbing pain, and she has an enhanced sensitivity to pain. So we know that this is something going on with the somatosensory system. And from looking at other T2 cases, scans that were provided in the case study, there was no lesion or tumor. So we know that something is going on with the somatosensory. And from this diffusion one that we have here, we can see that the spinal thalamic tract is very narrow. She did begin to feel those headaches and in both the frontoparietal occipital area. And sometimes when you're presented with headaches, it can be difficult to narrow down what exactly is occurring. And this case is kind of special because this case has presented like evidence that you can have a traumatic brain injury, which is what this patient is suffering from. And you can have damage to your spinal thalamic tract with that headache. So they believe that the headache was attributed to this injury of the spinal thalamic tract based on the symptoms. And they did use gabapentin to kind of provide evidence for this because she did have a good response to it. And this gabapentin is just like a drug specific for neuropathic pain. And it helped alleviate those headaches and made it a little bit manageable. So basically, the spinal thalamic tract is very important in our somatosensory system. And the diagnosis of this was the headache was due to injury of the spinal thalamic tract. There was no lesions or tumors, so we know it wasn't that. And this patient did have traumatic brain injury.
For case study number 4, we have a 36-year-old woman who suffered a fall, and she experienced persistent left hand pain and weakness. And over time, she also experienced leg weakness and patchy loss of pinprick occurred on both sides. And so as far as the symptoms go, we know that there's probably something going on with the somatosensory system because she's having the weakness and pain and the weird pinprick sensation going on. And so we can see in the scan, when we look at it, we want to know what exactly we're looking at. And it's obviously a scan of a spine. So it's a sagittal T2 weighted MR. And what it actually shows is that there is an arachnoid cyst near the cervical and thoracic areas of the spine, a pretty big one. And And so even though this woman suffered a fall, it actually wasn't from the injury that was resulting in a lot of her pain and loss of feeling, kind of weird sensations. And so it would make sense that these are being affected because the lateral cortical spinal tract is being affected, and also the posterior column seems to be affected. And since it's on both sides, we can also assume that, as I said, the cyst must be pretty large because it must be kind of filling up or taking up space in that entire spinal column. And so that would directly relate to her symptoms and sort of those somatosensory like deficits.
In our last case study, we have a 73-year-old man. He had a sudden onset of sensation that his left hand didn't belong to him. He also had difficulty recognizing objects with that hand. And he was examined 48 hours after he came in with these symptoms, but he didn't have any hemianopia, limb weakness, hyperreflexia, and he had no Babinski sign. For the sensory examination, his pinprick sensation was equal in both hands. Cold and warm sensations were normal with water tubes at 20 and 37 degrees Celsius. And he did have a decreased recognition of shapes and size and texture of an object placed in the palm of his left hand. And he couldn't recognize that object that was placed in his hand, even if he examined it with his fingers, either passively or actively. So we can tell that he's having trouble with recognition. And basically, some of his symptoms that he had is tactile apraxia, clinical deficits. We noted that it was only on the left side only. And we did also note that he had a history of cigarette smoking and alcohol abuse. So potentially, if he had a lot of cigarette smoking, we could think about cancers in that aspect. But the symptoms the patient is experiencing that is really good to know is he's unable to recognize his left hand belonging to him. So we know that there is some somatosensory issues here, and that those clinical deficits are on the left side only. For tactile agnosia, that is a key giveaway. Agnosia is caused by lesions. So we can note that maybe there's potentially a lesion of some sort. And agnosia, again, is just like usually caused by lesions on the parietal, temporal, or occipital lobes of the brain. And these lobes store information with language and such. The next one that we can kind of think about is what we can conclude about the symptoms of this recognition, that he had like problems with recognition of both properties, so micro and macro geometrical objects. And when we were looking at our scan that we're finally given, we can see that it is obvious with this flare axial section of the brain that there is a hyperintense lesion confined to the post-central gyrus on the right hemisphere. And there is also a smaller lesion on the prefrontal cortex. And lesions affecting the primary somatosensory cortex produce characteristic symptoms, so such as like loss of vibration, proprioception, and fine touch. And we know that that there is a lesion in this post-central gyrus. It's basically injuring some of like the primary somatosensory cortex, which is a main sensory receptive area for the sense of touch. And there was no follow-up with the patient because he denied it. And we know that the somatosensory was affected because of those lesions in both of those areas and how it's confined to the post-central gyrus there. So what we can conclude from our research is the somatosensory system is responsible for perception of pain, temperature, touch, vibration, and joint position. It is also important in animals such as the star-nosed mole. And basically from our research, we have found that different damage to this complex system can be very different as we've seen in our case studies. So like lesions, other additional ones are like strokes, traumatic injury, and more, can result in this wide array of symptoms to the patient, depending on the location of the damage. So some patients were fine, and some patients towards the end were not fine. So as a consequence, the somatosensory system can be disrupted and lose partial or total functionality. And basically, thank you so much for listening, and here's our references. Okay, we're at 19 minutes.